It's now my privilege to just introduce Matthew Boulton, who is the Associate Dean for Practice and the Director for the Michigan Center for Public Health Preparedness, who will introduce our featured speaker for this next sequence. Matthew, where are you? You're here.
On behalf of the University of Michigan School of Public Health, I'd like to welcome you all to today's conference. A few weeks ago, I was introducing Ken Warner, the Dean of the School of Public Health, and it suddenly occurred to me that I used to be asked to give talks, and now I mostly introduce other people who are giving talks. Made me wonder if my career is in its ascendancy or descendancy, but I noticed that President Coleman only provided introductory comments, so I'm taking that as an important sign of career growth for me. The most recent issue of Findings, the School of Public Health's biannual publication, was entitled Depression, the Public Health Dimensions of an Ancient Scourge. The public health community has been slow in recognizing the importance of depression specifically and mental health generally and its impact on the well-being of populations. Before coming to the university, I worked for 15 years in the Michigan's public health system, first in Detroit as a public health physician and later as the chief medical executive for the state health department. And in that time, I rarely observed any sustained collaboration between mental health and public health, despite them being located organizationally in the same state department. However, public health is in transition. And increasingly, we are turning our attention to exploring the socio-cultural context of disease acquisition and considering mental health a fundamental public health issue. Interestingly, what has helped to move that acknowledgement forward is the prominent national role of public health in emergency preparedness and response to disasters. Public health has come to recognize that disasters, whether man-made like the anthrax mailings or events of 9/11, or naturally occurring as Katrina or an outbreak of disease like SARS, can have long-term mental health implications. I can think of no better person to address the complexities of these issues than this morning's speaker, Dr. Sandro Galea, who just this last week appeared in Time magazine for his research into looking at how people respond to emerging diseases. Dr. Galea is an associate professor of epidemiology at the University of Michigan School of Public Health and also a research affiliate of the Population Studies Center at the Institute for Social Research. His research interests are the social and economic determinants of population health, the epidemiology of mental health and substance misuse, and the consequences of disasters and mass trauma. Dr. Galea has published more than 100 peer-reviewed articles in scientific journals, authored more than 20 chapters and commentaries, and co-edited 3 books in these areas. His ongoing research projects include the New York Social Environment Study that aims to understand how neighborhood-level factors influence the population risk of drug use and misuse in urban areas, the Impact Study, a study that aims to understand the role of micro-neighborhoods in shaping individual mental health and illicit drug use risk behavior, and the VIVA Study, a project that uses community-based participatory research methods to evaluate delivery of influenza vaccine to hard-to-reach populations. Dr. Galea has conducted extensive research in the aftermath of September 11th, terrorist attacks in New York City, the March 11th, 2004 train bombings in Madrid, and hurricanes Jean, Ivan, Charlie, Francis, and now Katrina in 2004 through 2006. Dr. Galea is co-director of the Disaster Research Education and Mentoring Center, an international resource for investigators pursuing research questions after mass traumas. He is also an elected executive board member of the International Society for Traumatic Stress Studies, an elected member of the American College of Epidemiology, and a fellow of the New York Academy of Medicine and the Royal Institute of Public Health. Dr. Galea did his graduate training at the University of Toronto Medical School, the Harvard University School of Public Health, and the Columbia University Mailman School of Public Health, and completed residency training in family and emergency medicine. And I might add one final note. I remember in a committee when we were considering interviewing Sandro and trying to bring him to the University of Michigan, that one of my colleagues leaned over and he said, we were looking at Sandro's CV, and he said, you know, it looks like this guy published almost 30 papers in 1 year. And I was thinking to myself, I don't even read 30 papers in 1 year. But such is the nature of this morning's speaker, Dr. Sandro Galea.
I may borrow your pointer though.
And you need a pointer, so it's right here.
The bottom. Good morning. Thank you to the organizing committee for inviting me to speak, and thank you to all of you for being here, and to Dr. Boulton for his immensely kind introduction. You're doing very well, this introduction business. You should stick with it. I'd like to see what's like next year when you introduce me for something else. I was asked to start off the meeting by trying to situate the thinking, the academic thinking about disasters and mass traumas in the larger literature. And what I thought I would do is give you both an overview of how we can think about disasters and mass traumas generally, and then focus in on some specific examples from some of the work which I have done, which hopefully will help both give you food for thought and guide some of the discussion later. So having said that, let me wade right in, and that's my email in case somebody wants to contact me later. I think it's fair to say that interest in public health, in mass traumas and disasters has been episodic over the past decade, but two events have really, I think, concretized the importance of disasters. First was September 11th, which, of course, was 5 years ago. And a number of people said after September 11th, well, now everything changes and we won't forget about disasters again. And, well, then we did, until Katrina came. And now we say, well, disasters now really are important and we won't forget about disasters again. So hopefully that these terrible events are helping us come to grips with the importance of mass trauma and how mass trauma may play a role in population mental health. And I quite like this picture because I think some of you may have seen it. It really illustrates to me very simply, very visually, the scope of some of the forces that we contend with, in this case sort of force of nature, with this enormous hurricane as it bears down on the southeastern United States. And the only other concluding point about Katrina I will make is I think what Katrina brought home is that these events have massive importance. This is Mississippi and Louisiana, and what you see here is different shading from a point of view of areas that the Federal Emergency Management Agency declared disaster zones. And the only point I want to make is that the areas declared disaster zones in Mississippi and Louisiana were larger than the entire United Kingdom. So I think it gives us a little bit of a sense of the scope of these mass traumas, and it's really hard sometimes to fully grasp that unless one is right in it. And I know that some of the speakers that are going to follow have had direct first-hand experience with being in New Orleans. So here's what I'm going to try to do. I'm going to start off by trying to frame what a disaster is and how often disasters happen. And then I'm going to give us a little bit of a framework for how to think about psychopathology after disasters. I'm then going to go straight into 3 examples from some of the work I've been involved in to highlight what I think are 3 key points that emerge, not just from my work, but from the broader literature about the mental health consequence of disasters, and then we'll conclude with hopefully a cogent wrap-up. So let me start off with what is a disaster and how often disasters happen. There are, I could spend an hour boring you to tears with academic debate about what is a disaster, so I chose not to do that. I think there are probably as many definitions of disasters as there are academics who think about this, but these are just 3 of my favorites, and it's a sort of highly idiosyncratic take on these definitions. But the reason I like these is because they highlight what I think is a central theme of the mental health consequence of disasters, which is the fact that disasters are social in nature. So if you see here, the first definition talks about how disasters involves a social system destabilization. The second definition talks about how disasters fundamentally involve social disruption and harm. They generate a collective response, and importantly, in theory, the consequences of disasters can be mitigated. It doesn't say the consequences of disasters can be prevented. It doesn't say disasters can be prevented because it is very clear that disasters are going to happen and will keep happening despite our best efforts. But what it does say is that by understanding the social nature of disasters, we probably can do something to mitigate their consequences. And the third definition talks about the fact that disasters fundamentally are potentially traumatic events that are collectively experienced. And I think the key there is that they are potentially traumatic events, that disasters may happen, but their consequences can be mitigated because the trauma does not necessarily have to have the adverse mental health consequences that frequently they do have. And I think it's the point of meetings like this one to try to understand these mass traumas so we can mitigate their consequences. So instead of trying to do what academics like to do, which is sort of come up with a nice pithy 40 words that define disasters, I think it's perhaps more useful to think of the qualities of disasters. And I think if we think of the qualities of disasters, we can understand a little bit better what we might expect the consequences of a particular mass trauma to be. And you'll note in my talk that I'm using the term disasters and mass traumas interchangeably, because I think fundamentally from how I look at the world, the two really are referring to the same thing. So a lot has been made of the different causes of disasters. So typically you have definitions like natural, technological, human-made, intentional, non-intentional, or war. And for example, with things like Katrina, I know there has been substantial debate about, well, was Katrina a natural disaster, or was it a human-made disaster because of the failure of the levees and other aspects of disaster like that? I'm not particularly interested in those kind of debates because I don't think it really matters. I think what matters is understanding the scope of the disaster and its potential consequences. And as such, I would suggest that it's useful to think of disasters sort of in a type by severity matrix. And what I have here is sort of the different types, which, as I said, are pretty fungible. But most importantly, we have space, time, and intensity. And if you think about any mass trauma, mass traumas are going to be realized over a certain space, a certain geographic space, a certain temporal space, and have a certain intensity. And we have, just to give a couple of examples, you can think of a natural disaster that is localized, or you can think of a natural disaster that is over a large geographic area. So Katrina was obviously a disaster which covered a large geographic area. September 11 terrorist attacks, which are sort of before Katrina, certainly the previous disaster with the largest press, were actually a very localized disaster. It wasn't a natural disaster, but it was a very localized disaster. The area of New York City that was affected was in fact very, very small. Disasters also take place over time, and there are different characteristics of disasters over time. We can think of an acute or a chronic disaster. We can think of an anticipated or an unanticipated event. And the degree to which an event is anticipated means that there is much greater opportunity for public health preparedness and fundamentally much greater opportunity for mitigation of the mental health consequences of that mass trauma. And at the end, when I come to my conclusions, I will talk a little bit about how we can apply public health thinking to this matrix where the notion of anticipated versus unanticipated becomes very important. Similarly, acute versus chronic. Again, the September 11 terrorist attacks versus Katrina are a nice example because the September 11 terrorist attacks in many respects were the most unanticipated acute event you could imagine. Nobody predicted it, although presumably there were sort of intelligence reports which weren't listened to, which could have, but nobody predicted it. It came, and then it went. It was a very acute, unanticipated event. Katrina, on the other hand, there was much more meteorological data which could have given us an indication, again, had we listened to the fact that this was an anticipated event, and it played out over many days and many weeks. So that gives you a bit of a sense of the different dimensions of acute versus chronic, anticipated versus unanticipated. And intensity. A lot has been made in sort of the scientific literature of measurements of disaster intensity. And in fact, we have accepted scales to measure intensity of earthquakes, like the Richter scales, for example. In things like chemical leaks, typically these are measured by intensity in terms of how close they are or how far they are from populated areas. And there's multiple different ways you can imagine measuring the intensity of any given disaster. And I think the usefulness of thinking about this kind of matrix is that one doesn't have to rely on semantic distinctions between is this a disaster, is it not, is it a mass trauma, and it's not. What matters is that within the rubric of a collectively experienced event, as sort of we saw in the earlier definitions, which is potentially traumatic, one can think about categorizing that kind of event along its space, time, and intensity. So taking sort of an even broader picture for a second, I know that we are dealing here with sort of domestic concerns, but I think it's important just for a second to think a little bit more broadly about, well, what is the global geography of disasters and how are we doing compared to the rest of the world? And this is from the Columbia University Earth Institute, and is it project well? Yeah, you can actually see this reasonably well. And what you see here are, this is their disaster risk project, which is quite good. And what they've done is they have mapped the risks from specific natural disasters, only natural disasters in different parts of the world, and dealing with things like typhoons and floods and droughts. And what you see here is the different colors represent different kind of disasters, but you see the areas of the world which are more susceptible to specific kind of disasters, and this is specifically mortality risk. There is a distinction between areas that are high risk for mortality or high risk for economic loss, for example. And if you look at the next map, it's from the same group, which highlights the risks for economic loss. And the reason for that, of course, is because disasters may hit densely or less densely populated areas, or areas which are economically productive or less economically productive. And the point I'm trying to make here is that, first, there is a global risk of disasters, and different parts of the world are at different risk. And the second thing is that the consequences of this global risk can vary both by type of disaster as well as by the particular area globally that is at risk for that event. So just putting some numbers on this, most studies suggest that about 1 in 10 US residents will experience a disaster during their lifetime, and more than a third of United States residents live in areas that are declared hazard prone, and by that we mean prone to natural disasters, which is where most of the disaster risk prediction happens, because natural disasters follow some sort of pattern, much more so than sort of intentional terrorism and things like that. About 20% of the Earth's land area is exposed to at least one natural hazard. About 160 countries have more than a quarter of their population, which is an area of high mortality from one or more hazards. And there are some countries, which is sort of the bottom bullet, where 90% of the population are living in areas at high relative risk of death from natural disasters. These are areas like Bangladesh, Nepal, Burundi, Haiti, Taiwan. And these are areas which you hear about time and time again in the press in terms of suffering from disasters. And the reason for that largely is because of their situation and the fact that they are predictably at high risk for disasters. So I just want us to, just for a second, take a global view before coming back into our own particular concerns. The academic literature on disasters is fragmented across multiple disciplines, but I'm focusing primarily on the public health and the public mental health literature. Most of the papers that talk about disasters and their consequences in the public health literature focus on natural disasters. This is what you see here. There is a smaller group of research on sort of technological disasters, and then an even smaller group on mass violence and sort of terrorism and intentional events. And of course, in the literature, as one might expect, there is a mismatch between the prevalence of disasters and the prevalence of academic publication. As is frequently the case, academic publication bears little resemblance to the real world. And this is from a meta-analysis that we have done focusing specifically on terrorism. And what you see is the dark bars are the number of terrorist events. The light bars are number of studies about terrorist events. So what you see is North America, dark bar, light bar. Middle East, number of events, number of studies. Asia, number of events, number of studies. I think the point is made. So, I mean, I'm not sure what to do about that, frankly, but I just thought it was worth, in the spirit of an academic conference, to outline the fact that sometimes our focus is a little bit biased by academic direction, which doesn't necessarily reflect the real world. Okay, so let's move on to the central concern of this conference, which is the psychopathology after disasters. What are the consequences, what are the mental health consequences of these mass traumas? And of course, this is being presented in the spirit of trying to understand the mental health consequences of these events in order to try to mitigate them. So I think those of us who are interested in epidemiology of mental health, we sort of frequently sort of talk about how, well, mental health tends to be overlooked, and I think Dr. Graydon did a very nice summary and introduction about the centrality of mental health to burden of disease. And a lot of that has to do with the fact that mental health has only recently been able to codify itself in a way that's commensurate with what some other physical health disciplines have done. However, having said that, I think we frequently forget that the codification of psychopathology does not mean that we've invented psychopathology. And in fact, psychopathology has been present throughout history. And this is sort of one of my favorite early references to disasters and their consequences. Samuel Pepys, who kept a famous diarist, of course, in England, he was in the Great Fire of London in 1666. This is from a wood etching of the Great Fire of London. And he gives, anybody who's interested in this, it's quite a vivid read. He gives a very vivid description of his experiences of the Great Fire of London. He talks here, rode down to the waterside and he saw the lamentable fire, everybody endeavoring to remove their goods, flinging into the river, bringing them into lighters that lay off, poor people staying in their houses as long until the fire touched them. And he gives a very compelling read of the horrendous experience of the Great Fire of London, which, by the way, destroyed about 80% of London at the time. And then, if you read his diary over the course of the next year, he gives a very vivid description of what today we would call classic post-traumatic stress symptoms. That he was having nightmares, he was having dreams of the fire falling down of houses, he couldn't sleep without dreams of the fire, he was avoiding buildings. So he gives a very, very clear description. It took about a year, whereupon his symptoms resolved. So that was sort of going back, 400 years. And then moving on to a little bit more of a current example with Robert De Niro and his contribution to the field. I was there are a couple of reasons why I chose these three movies. First of all, because I like all of them. The second part is because they're all before 1980, which is when post-traumatic stress became a disorder, as I'm going to show you in a second. But all three movies very clearly depict post-traumatic stress. And I wasn't sure if it was a coincidence that sort of Robert De Niro was in two of them. These movies were definitely part of a great social growing awareness of the consequences of traumatic event experiences, which came about in the 60s and 70s, largely precipitated by the Vietnam War and returning veterans, and which led to post-traumatic stress disorder becoming an official disorder by the American Psychiatric Association. I would like to just, for a brief moment, make reference to the fact that just because the APA made it an official disorder in 1980 doesn't mean it didn't exist before 1980. I think it's an important distinction. The concepts that led up to post-traumatic stress have sort of been around for over 200 years and have variously been called things like neurosis, shell shock, railway spine, survivor syndrome, post-Vietnam syndrome, and all of which sort of became subsumed into this notion of post-traumatic stress disorder. Now, post-traumatic stress disorder certainly is not the only consequences of traumatic events, as I'm going to discuss in a second. But the reason I have a slide about it here is because the recognition of post-traumatic stress disorder as a psychological disorder with explicit links to traumatic event exposure helped to galvanize research in the area and helped to make it very clear that there are explicit mental health consequences of trauma, both individual trauma as well as mass trauma. There have been a number of disaster events which have been important at different stages of the development of the academic literature about this. I'm just listing them here, including things like the Buffalo Creek Dam collapse, Chernobyl, Hurricane Hugo, and there were key studies after each of these events which I think have brought us to where we are today in our understanding. So, having said that, sort of what can we learn from these studies? And as I said in this first part, I want to give you some general frameworks. Well, I think it's useful to think of the people who might be affected by mass traumas as well as the psychological consequences of mass traumas using this heuristic. And this heuristic sort of involves a big rectangle at the bottom and then this pyramid. And starting off with the people affected by disasters, what you see is as follows, is that at the mass trauma happens and there are levels of people affected. And it's just starting off from the top. The number of people killed or injured in any given mass traumatic event, barring the most catastrophic of events, is going to be minuscule compared to everybody else who might also be affected in varying degrees by mass traumas. This is also true for very large events like Katrina or September 11th. So although this is a heuristic, the proportions for each of these segments of the pyramid are actual proportions which I calculated from some September 11th studies. That September 11th was the largest single intentional loss of life in the US in one day since the Civil War. So you would think there would be a large loss of life, which it was. It was a huge loss of life. But 3,000 people who lost their lives in September 11th were nested within 8 million people in New York City. So proportionately, the number of people who are killed or injured are really the tip of the iceberg. Under the people who are killed or injured, we have the families of those who are killed or injured, which were also affected, as we'll get to in a second. Then, and this is a group that I think is frequently forgotten, especially when we're trying to think of ways to mitigate the consequences of disasters and mass traumas, are rescuers. There is typically a large body of people who are involved in some capacity or another in rescuers. And I would make a case for the definition of rescuers to be a fairly broad definition that includes not simply firefighters and police officers, but also volunteers who frequently are less trained than firefighters and police officers and experience even more horror than do the trained professionals. Then there are people who are in proximity to the event. So that means that there are people who, when a sort of particular mass trauma happens, weren't right there. They weren't killed or injured, but they were around. Then you have this other group, which increasingly, I think we're beginning to appreciate, tend to be at high risk for long-term consequences of psychopathology after these events, which is the families of the rescuers, who are, again, I think have typically been neglected. And all of that is nested within the general population. Now, it is very clear from all the trauma literature and from all the mass trauma literature that the intensity of one's exposure to the potentially traumatic event, to the disaster or to the trauma, is one of the greatest and probably the single sentinel risk factor for development of psychopathology. So what that means is that going up this pyramid, we have greater risk of psychopathology. That those who are injured are at highest risk of psychopathology, more so than their families, more so than rescuers, and all the way down. Now, of course, this is a device, and that it is certainly possible that in particular circumstances the rescuers are higher up on the pyramid in terms of risk of psychopathology than they are lower down. So I don't mean this to be written in stone, but I think it's a useful way of thinking about risks of psychopathology as varying by level, severity, level of exposure. And just one more point about this. You'll notice that the general population, which is by far the largest group here, although it's at the lowest risk of psychopathology, is not excluded from the risk of psychopathology. And I'm going to come back to that later. So within the same device, I think we can also think of the psychopathology itself. So what are the mental health consequences of these events? So we've talked about the people who might be at risk. Now, what are these mental health consequences? Well, again, we can start off, I think, with the same schema. And I think the consequences of these events can go from the bottom all the way to the top. So let's run through each one of them. The first and central point is that most people who experience mass traumas or disasters are resilient. And I think this is frequently something that's overlooked by those of us who are in epidemiology or in public health or in mental health, because we are interested, of course, in helping those with disorder. So we tend to forget that most people, in fact, are resilient and do just fine. And I think this is sort of we have a couple of papers published about resilience, which I sort of want to put down there. Then, building on from resilience, we have a hierarchy of mental health consequences. I'm using the term mental health consequences judiciously here, because I think concerns or behavior change leading to non-specific psychological distress are elements which are not necessarily psychopathological. In certain circumstances, concerns may in fact be normative rather than pathological. However, there's very clearly sort of an ascendance of mental health responses, including concerns, non-specific psychological distress, moving on to acute stress disorder, short-term psychopathology, and psychopathology that goes on in the long term. And I think it's useful, again, to sort of recognize that this represents a scale of severity of the mental health consequences. That obviously we who are in the area of trying to mitigate the consequences of mass traumas and disasters, who are trying to mitigate the consequences of these events, fundamentally want to prevent or minimize to the extent possible the long-term psychopathological consequences of these events, which of course we know are going to be most debilitating. Apart from sort of having a bit of a severity pyramid, these responses also follow over a temporal scale. And this is, again, just a very simple heuristic, but In the short term, after disasters, what you see typically is a change in sort of some of these, let me just go back for a second, some of these concerns that we talked about here, which typically do change, do rise, but then drop very quickly, typically in the first month to 2 months after these events. Then we have a layer of sort of acute stress, which is some of which can fall into DSM categories of diagnosis, some of which does not. And then we also have more long-term post-traumatic stress or depression and psychopathology. So you have these waves of different mental health reactions to these events, and depending on where you measure, you are likely to sort of find different amounts of each of these mental health responses. Now, for the rest of my talk, I am mostly going to focus on long-term psychopathology and short-term psychopathology, and I think the reason for that is because, as Dr. Graydon said in his introduction, we're interested in trying to understand and minimize these consequences of trauma, in both sort of from a general population point of view, as well as within the specific context of campus health. In the public health, disaster, mental health literature, most studies have focused on post-traumatic stress disorder, depression, and generalized anxiety after disasters and mass traumas. The slightly tricky part is understanding whether or not post-traumatic stress, depression, and anxiety truly are the most common psychological consequences of disasters. And the bottom line is that they probably are up there. It's hard to know exactly if they are the absolute most common consequences of disasters because there have been very few studies that have comprehensively assessed the full spectrum of psychopathological consequences of mass traumas and disasters. But I think it's fair to say that if we are concerned with the consequences of individual mass trauma, we need to be concerned about generalized anxiety, depression, post-traumatic stress. And this is another slide from a review we've done, which looks at, this is specifically focused on terrorism, and we looked at the number of studies that have studied what, and what you see is that most commonly studied is post-traumatic stress. You then have depression. In the context of terrorism, there have been a number of studies that have looked specifically at behavioral outcomes, and then you also have stress anxiety, which includes generalized anxiety. So these are the consequences that typically are studied, and the other reason I want to show you the slide is because although I'm not going to touch on it in this presentation, there is a growing body of literature that in the long term, after experience of mass trauma, there is going to be an intersection between long-term psychopathology and long-term physical health, including things like cardiac health, respiratory health. And probably one of the biggest burdens of long-term psychopathology is going to be, over time, the intersection between long-term psychopathology and long-term physical functioning. And that's sort of another area which is subject of another discussion. Okay, so having said that, what I want to do now is show you some data from 3 disasters, mass traumas that I have been involved in doing some work about, which I think each of these studies illustrates one central point, which I hope will translate sort of to the rest of your discussions today, because I think these are fairly generalizable points. So the first point I want to make is this one, is that there is a substantial burden of psychopathology in the general population after disasters. So I want to illustrate this point by showing you the study which we did after the March 11, 2004 train bombings in Madrid. This is a picture from the train where one of the bombs happened. For those of you who don't remember the event, on March 11th, 2004, which was exactly 2.5 years after September 11th, 2001, 10 bombs detonated at the same time on 4 different commuter trains which were going to Atocha Station in downtown Madrid. About 1,400 people were taken to hospital, almost 200 people died. This was the largest single terrorist attack in the European Union. And what is not well known and sort of relevant to the context of a conference about campus mental health is that the death toll in the Madrid train bombings was supposed to be much higher than 200 people. The trains in Madrid, which went from, this is a picture of Madrid. For those of you who don't know, Madrid sort of is a bit of a concentric city, and the trains, sorry about that, I'm pressing the wrong button. The trains went from Alcalá, which is a suburb of Madrid, down to downtown. Alcalá is a sort of a lower rent suburb than the rest of Madrid, and two groups tend to live in Alcalá. One is a lot of workers, a lot of blue-collar laborers, and the other group is students. And typically, at the time of the trains, the two groups that are crowding the trains are workers and students heading to work in Madrid and or heading to school. On March 10th, 2004, in the evening, it's a sort of an interesting outcrop of strong European labor laws. The teachers' union of Universidad Complutense de Madrid, the largest university in Madrid, declared a one-day wildcat strike to protest something, which now I don't remember. And so classes were closed on March 11. So March 11, 2004, in the morning, there were no students on the trains, which the trains typically would have been filled with students. So there was sort of a little bit of a side that's related to this. So here's what we did after this study. We conducted a couple of studies that looked at depressive and anxiety disorders, and we looked at 4 different groups. And as you'll see, these 4 groups that we looked at mirror a little bit sort of the schema that I gave you about who might be affected by these events. We looked at the general population, those who were injured in the bombings, police officers involved in rescue efforts, and residents of the general population of Alcalá, where about 20% of the victims came from. We actually done a series of studies, but this is specifically, these were about in-person interviews, and all this was done between 1 and 3 months after the attacks. And actually, this paper is coming out this month. So this is, I showed you a picture of Madrid already. So this is the prevalence of post-traumatic stress disorder after the March 11 train bombings in Madrid. So what you see is a substantial difference in the prevalence between the injured and the general population of Madrid. First of all, this over here is the baseline from the European studies that establish more or less what one would expect post-traumatic stress disorder to be at baseline absent this kind of event. And what you see is that among the injured, about 44% of them had prevalence of post-traumatic stress disorder. In the population of Alcalá, which was a general population sample, but is the group from where a lot of the victims came, so this is a group that involves a lot of family members and friends of victims, is about 12%. The police, it was about 1%, and in Madrid city itself, it was about 1.6%. I will come back to the Madrid city number at the end, because this is actually a particularly low number, which stands in nice, sharp contrast to what we saw in New York City. So that was post-traumatic stress disorder. This is taking the post-traumatic stress disorder among the injured, the population of Alcalá, and the police, breaking it up into specific symptom group, which I won't get into here, but the only point I want to make here is that the patterns of symptoms in each of the 3 groups, despite the tremendously different prevalence, were very similar. And this is depression. This is depression, again, 1 to 3 months after the March 11 train bombings, among the injured, the residents of Alcalá, the police, and the residents of Madrid. Now, the one point I want to make here is that you'll notice that the prevalence of post-traumatic stress disorder after this event in general population of Madrid was quite low. Not so with depression. The prevalence of depression in general population of Madrid was actually pretty comparable to general population of Alcalá, although both are quite a bit lower than the prevalence of depression among those injured. This is, I think, important because it introduces the point that not all psychopathology just happens after these traumas, that in fact there are very explicit characteristics of specific mass traumas that may result in one form of psychopathology or another in very specific groups. In particular, post-traumatic stress, some of our work has shown and some of the work of others has shown, is probably influenced most by the extent to which the mass trauma or the disaster is visible and effectively traumatic to greater number of people, while depression probably is much more of a process which reflects underlying societal grief. In fact, if you go back here, the trains where the bombing happened on March 11th were largely not visible to residents of the city of Madrid. It was possible to go about your day in Madrid and not know that trains had been bombed unless you're sort of watching television, which was not quite this, which was of course not at all the same in New York City, where the World Trade Center was so visible that there was a far greater number of people who were exposed to the trauma itself. And as I'm going to show you with New York City, the prevalence of post-traumatic stress was much higher than it was in Madrid, but the prevalence of depression was very similar. So there was depression, and this is anxiety. And this is the prevalence of anxiety disorders among the injured Alcalá police. And again, making the same pattern. Now, this is the summary table. And the point that I sort of started off making here is that there is a substantial burden of psychopathology after mass traumas and disasters. Now, notice I did not label this section that there is a substantial burden of post-traumatic stress, or there is a substantial burden of depression, or there is a substantial burden of anxiety. The reason I did not is because what tends to happen in the literature very frequently is that you have a paper that's written that talks about the prevalence of post-traumatic stress after an event, or a paper about depression, or a paper about anxiety. What we frequently don't have access to is evidence about the complete burden of psychopathology. And if you look here, any mental disorder among the injured is about 58%, among the residents of Alcalá it's about 29%, and among the police it's about 6%. Now, I'll make a quick point about the police here. The prevalence of psychopathology among the police in this sample is particularly low. I would have expected this, based on the previous literature, to be about 10–15%. It's unclear why it's so low in the sample, but I think the reason for it is that this is not your typical beat police officer. Because Spain has had a history of terrorist attacks, most of them propagated by ETA, which is a Basque liberation group, although none of them have been of this magnitude, they have this squad of highly trained terrorism response police. So in this sample, 3/4 of them had previously done something after a previous terrorist attack, and the group is highly selected for psychological resilience. So the prevalence here is lower than what might expect. In fact, it's probably surprising that it's even this low, given how elite, this high, given how elite this group of police officers is. Okay, let me move on to the second point now. The second point is that, unfortunately, the course of this psychopathology after disasters is likely complicated. I say unfortunately because everybody in this room is in the business of trying to understand psychopathology, and in this particular case, you're interested in understanding it after trauma and after mass trauma. And as a result, for any of us who are trying to understand something, we would be better served if the course of psychopathology was simple, if I could tell you it was a simple monotonic decline. But it's not the case. And let me show you that by showing you some data from some studies which I was part of after the New York City terrorist attacks on September 11th. So briefly, this was the study. What we did is we did a series of studies starting 1 month after September 11th and moving on to 4 months, 6 months, 1 year, 2 years, and we even finished a 3-year follow-up, which I don't have data on here. We sampled the entire New York metropolitan area, not just New York City. So for those of you who don't know the area, this is New York City here. That's where the World Trade Center is. And this is Long Island. This is Southern Connecticut. This is Eastern New Jersey. And the reason for different colors is because we oversampled the closer we got to the World Trade Center. This is just from one of the samples, just to give you a sense of the fact that the people we surveyed were very similar to what one might expect in the general population. And in fact, if you compare the proportion from our study here to what you might expect in the census, you find they're very similar groups to what you find in New York City. New York City has typically, it's about, so this particular slide is Manhattan. It's about 70% white compared to about 64. We oversampled white a little bit, Hispanic, black, etc. This is a map of Manhattan, and I want to show you these two maps just to give you a sense of why I made the comment earlier about the burden of post-traumatic stress in New York City being particularly high, as I'm going to show you in a second. In many ways, the September 11th attacks on New York City were ingenious, and and the reason for that is because they were attacks that happened at a time in a place which, given the economic geography of New York City, essentially is a funnel for people in the New York metropolitan area moving towards the terrorist attacks. And just to give you a sense, this is a map of Manhattan, and each dot is where people lived who were part of the study. So we geocoded them to a street intersection. We didn't have the street address for confidentiality, but we had the intersections. And what you see is, for those of you who know New York City will know that this to be true. This is Manhattan, that's Central Park. Everybody in New York City lives in the Upper East Side or Upper West Side. Nobody lives in the Theater District. People live in the East Village and the West Village, and very few people live in the Financial District, and the World Trade Center was down there. So this is a slide of where people lived. Then we also geocoded where people were at 8:46 in the morning on September 11, 2005. And if you look at those dots, what you see is that the Upper East Side and Upper West Side have emptied. People have now moved to Midtown, and people have moved to the financial district. I'll show you that again. That's where people were living. This is where people were moving. And I could show you similar slides that show the entire periphery. So essentially, the city was moving toward these terrorist attacks. As a result, the prevalences of event experiences were quite high, higher than what might expect. We estimate about 20%. 1 in 5 people saw this event in person. These were very tall towers, very visible towers. About an equivalent percent say they were afraid of injury or death, which makes sense that the two numbers would be very similar. About 15% had a friend or relative killed. That does not include acquaintance or a coworker. That's sort of a separate category, which I'm not showing you here. About 9% of people were involved some way or another in the rescue effort. And this is sort of part of my earlier plea that when we think about the rescue effort, we think much broader than just thinking about police officers and firefighters. We estimate that about a quarter of New Yorkers, so it's about 28%, were in some way directly affected by September 11 attacks. And now one could argue about what really is directly affected or not, but the point I want to make is it was a substantial proportion who were in some way directly linked to the attacks, and I'm going to use this variable in a second. So here was the prevalence of post-traumatic stress in New York City after September 11. Now there's a lot of numbers on the slide, so just focus on 2 of them. This is the prevalence of post-traumatic stress that was linked to the September 11 attacks in the first 6 months, and this is the prevalence that was remaining 6 months after the event. So this was post-traumatic stress. So about 7.5% had post-traumatic stress linked to September 11 attacks, and that number had gone down to about 1.5% at about 6 to 9 months, which was our 3rd survey wave. Now, from a public health point of view, I think one of our challenges sometimes is trying to understand what percentages like this mean in terms of general population. And if you apply that to 6 million adults in New York City, what you see is that 6 to 9 months after, 1.5% is the prevalence estimate, you still have about 90,000 people with post-traumatic stress 6 months after the event, while at any time in the first 6 months you had about 450,000 people who had post-traumatic stress. So these are large numbers when you apply even very small percentages, like 1.5%, to a large, densely populated urban area. So that's the burden of post-traumatic stress. Now let's talk about the course of psychopathology. Oh, this is actually, before I talk about the course, I just want to show you one thing about the geography. This is the darker the color here, it was the greater the population prevalence of post-traumatic stress in New York City. And what you see is that the Bronx and Brooklyn are higher, more dark than Manhattan. The other thing you see is that it's darker here, and it gets lighter as you go out. So you have lower prevalence of post-traumatic stress the further away you get from the trauma, which is exactly what you would expect given the intensity of exposure paradigm I showed you earlier. But the thing that's a little bit surprising is that Brooklyn and the Bronx were higher prevalence than Manhattan, which was counter to what we expected. And the reason for that was twofold. First is that Latinos were at higher risk of post-traumatic stress, I'm going to show you in a second. And the Bronx tends to be more heavily Latino. Second is that Brooklyn had a greater number of people who directly saw the towers, just because of sightlines, the way sightlines are in New York City. So let's talk about the course. This is the course of post-traumatic stress in the New York City population in the first 6 months after the attacks. What you see here is 1 month, 4 months, 6 months. And it's a fairly monotonic decline. And if you break up that line, so this orange line has now become a dashed orange line, it's the same line. And what we did here is I'm breaking it up into those who were directly affected, that's red, and those who were not directly affected, and that's blue. And what you see is that at every single time point, those who were directly affected had a greater risk of post-traumatic stress than those who were not directly affected, right? So the red is always higher than the blue. However, the key point is that the blue does exist, and we'll come back to that in the conclusion. So that was the first 6 months, and we published that paper. Fortunately, we spoke a little bit too soon, because when you extend this out to about 2 years, you see that that's the overall pattern. That the overall pattern is, in fact, a dip at about 6 months, and then a rise again to about 1 year, 2 years, and 3 years is about the same. And this pattern is hard to find in the literature because there are very few studies about the long-term consequences of mass traumas. And of course, from the point of view of those of you who are interested in and responsible for caring for people who have been exposed to mass traumas, it is important to know what happens 1 year, 2 years, 3 years later. The evidence that does exist corroborates this general picture, that you tend to have a dip in symptoms and the burden of pathology after about 6 months, which then rises to reach about stability about 1 year, 2 years after the event. The best, probably, other evidence about this comes from the Netherlands, where because every citizen of the Netherlands is linked to an electronic medical records, they have physician data on people who have been exposed to a couple of disasters, and they're able to follow people up both before and after disasters, and they see very similar patterns. The other point, again, if I take this orange line again and split it up into red and blue, which is those directly affected, those not directly affected, and what you see is you see exactly the same thing I showed you before, which is those directly affected have a higher prevalence of post-traumatic stress at every single time point, but there also is a prevalence, a lower one, among those who are not directly affected. So that's post-traumatic stress. Now, how about depression? Well, here's the pattern for depression. This is depression, again, going out 2 years after the September 11 terrorist attacks. The orange line, the orange dashed line, is the aggregate. And what you see in depression is a different pattern in post-traumatic stress. It's 1 month to 4 months, there's a dip, and then essentially this is, statistically speaking, a straight line. Essentially it's down to stable state after about 4 months. The other interesting thing you see in depression is that although at 1 month the red line is higher than the blue line, it's not so after you reach steady state. These two lines, again, are statistically indistinguishable, that essentially those who are directly affected are not at any greater risk of depression once depression reaches steady state after exposure to a mass trauma. And this is sort of getting a little bit at what I alluded to when I was talking about the March 11 train bombing data, that the etiology of post-traumatic stress and depression, as well as the risk factors for post-traumatic stress and depression after these kind of events, is probably substantially different. And I could sort of spend another hour talking more about that, but the bottom line is that post-traumatic stress is linked much more closely to the direct experience of the trauma, while depression, we think, is linked much more to the general societal experience and grief as a result of the trauma. I'll move to the third point. The third point is that while we're talking about population prevalences, and we are talking about a burden of psychopathology in the general population, we should not forget that within specific populations there are sentinel vulnerable groups, and that these vulnerable groups are likely to have substantially elevated prevalence of psychopathology compared to the rest of the population. I will illustrate that by showing you a study from Israel that I've been involved in. And as everybody knows, Israel has had the misfortune of suffering a number of repeat terrorist attacks, broadly speaking under sort of the rubric of the Al-Aqsa Intifada in the past 4 years. This is from one of the train bombings. And we did the study, which, so this is the Al-Aqsa Intifada, started in September of 2000, and it's estimates about number of casualties in the Al-Aqsa Intifada is very sort of hard to come by, but these are Red Cross estimates, about 3,000 Palestinian deaths, about 1,000 Jewish deaths. So what we did is it was a random sample study of the population of Israel, and we sampled both, we sampled residents of Israel, who could be both Jews as well as Palestinian citizens of Israel. This is specifically Israel within the pre-1967 boundaries. There's no interviews done here in West Bank or Gaza. But we're dealing with both within the population of Israel. Sort of broadly speaking, the two large groups are Jews and Palestinian citizens of Israel. This is the prevalence of post-traumatic stress among Jews versus Palestinians. And what you see, of course, is that there's a threefold greater prevalence of post-traumatic stress among Palestinians compared to Jews. This looks at the symptom profiles within post-traumatic stress. Again, very similar symptom profiles for both groups, despite the difference in prevalence. And then, through a series of studies, what we have been trying to do is we've been trying to explain why it is that Palestinians have such higher prevalence. And what you see here is, briefly, a series of statistical models, the last one of which takes into account sex, age, income, education, religiosity, economic loss, psychosocial loss, traumatic growth, and social support. And despite of all that, we can only explain about 40% of the greater gap between Israelis and Palestinians still have about a twofold, 1.9, greater risk of post-traumatic stress than Israelis in this context of the Al-Aqsa Intifada. And our thinking is that that's probably due to substantially greater underlying social and economic vulnerability of the Palestinians within the sample that we are not measuring despite our best efforts to quantify it in this particular group. So I'm going to try putting it all together. These are pictures from each of the three disasters I talked about. One of the things about this series of studies that it lets us do is because we've used almost identical instruments, because of similar research team, we're able to compare some of the prevalences involved. So this is looking at depression and post-traumatic stress from each of the samples. You start off on the left with New York City, moving to the middle with Madrid, moving to the end with Israel. And what you see is the lighter bar is post-traumatic stress, and the darker bar is depression. And what you see here is, if I actually overlay this, is that the prevalence of both post-traumatic stress and depression in the groups who I would call general population groups in heavily affected areas, which is the New York City population, the population of Alcala, and the population of Jews in Israel, is all within the same range. It's about 7.5 to about 12%, and that also is approximated by depression in the Madrid population. However, the exceptions are probably as telling about the processes that result in these psychopathologies as are the norms. What we see is a substantially lower prevalence of post-traumatic stress in Madrid, substantially higher prevalence of both post-traumatic stress and depression among those injured, and a higher prevalence of both post-traumatic stress and depression among Palestinian citizens of Israel, which I think hopefully illustrates the points that I started out to illustrate. So let's talk a little bit about risk factors. So who are the people who are most at risk for psychopathology? And I've already spoken about some of it. I've talked about the centrality of intensity of exposure. I've talked about group vulnerability. But what I did in this slide here is I tried my best to summarize the literature based on two key review papers, I think one of them by our research group, one of them by another research group, about what are the risk factors for psychopathology after these events. And I have here post-traumatic stress, depression, generalized anxiety, the three most commonly studied disorders. Unfortunately, I am not entirely sure if the boxes in which I don't have an X is simply because this is understudied or because it's not really the case. But briefly, younger age is typically associated with post-traumatic stress and with depression after these events. By the way, this is, in my opinion, a common misconception in the press after disasters, that if you look at any disaster, September 11th as an example, Katrina's example, you look at press reports about mental health consequences, there is inevitably, about a week after disaster, a number of press reports about how the elderly are at particular risk of post-traumatic stress after the event. It's actually not true. The age group that typically is at greatest risk of psychopathology after disasters tends to be young middle age. So we're dealing with sort of 30 to 50. The elderly do just fine. And in terms of younger, even younger groups, the picture with children is a little bit more mixed. Female gender, women tend to be at greater risk psychopathology. Hispanic ethnicity, which has been shown time and time again in North American samples, but fundamentally, probably, we're not dealing as much with Hispanic ethnicity, but rather with minority group membership, which in this country, it seems to manifest particularly in Hispanic groups. And this has been shown both in our studies as well as many other people's studies. Being single is important, although being single probably is more of a reflection of spousal support. So it's not just a matter of being single. Being married in a non-supportive relationship probably also puts you at greater risk. Low socioeconomic position. Prior psychopathology is unquestionably a risk for any form of psychopathology after these events. Low social support, job loss after the event, and intensity of exposure. And notice I put the sort of a parentheses around the X for depression with intensity of exposure because of the sort of complicated role of intensity of exposure in depression over time that I showed you with the September 11 data. A quick point about job loss. It is likely that job loss after the event is a sentinel determinant of the course of psychopathology. That job loss is important to determine the extent to which one will continue to have psychopathology in the long term, even more so than it is a determinant of psychopathology immediately after the event. And one of the things which I'm not getting into here is the fact that it's probable that the risk profile of those at risk for psychopathology changes at different points in time after an event. This is, just to sort of concretize it a little bit, from our best estimates from a review paper, in terms of prevalence of post-traumatic stress, this is very consistent with what I showed you in New York, Madrid, and Israel, that post-traumatic stress probably is about 30 to 40% prevalent in those who are injured. In the second tier, it's about 10 to 20%, and general population is about 5 to 10%. Given the interest of time and the fact that I want to take some questions, I'm going to skip special topics. I was going to talk a little bit about children and about comorbidity, but I'm going to skip that. I'm going to go straight to my conclusions. Okay, so let me just, I have two sort of concluding thoughts. One of them about the population burden of psychopathology after these events, and the other one about sort of public health perspective, how to take what I've talked about and apply it a little bit to a public health perspective that I think will be the focus of much of this conference. So just a reminder, I talked about this pyramid with general population leading up to those killed and injured, and I've made the point, and I think I've shown it in data, that the risk of psychopathology increases as you go up this pyramid. I've also made the point that the mental health response to these events start off from resilience all the way to long-term psychopathology. However, I don't want to lose the essential numeric facts that these points mask. And this is a schematic, but again, these numbers are based on actual data, but I'm using it here more as a schematic. If we take any large mass traumatic event, barring the most cataclysmic of traumatic events, the number of people in a given group who one might call directly affected by a given event is almost certainly going to be smaller than the number of people who are not directly affected. And that's a simple mathematical fact that, again, using September 11 as an example, killing 3,000 people is sort of, it's a big deal. But in a population of 8 million, 3,000 isn't that many. So the directly affected here are the red folks. The not directly affected are the blue folks. I've made the point, I hope everyone sort of now is, sort of buys it, that the red people are at much greater risk of psychopathology than the blue people. There's no question about that. But if you apply a very simple risk calculation, what you see, the yellow people are the people with psychopathology. Well, everybody can easily see that the risk of psychopathology among the red people is much higher, right? Because the risk here is yellow divided by red, which is higher than yellow divided by blue here. However, in absolute terms, the number of yellow people in both groups very easily approximates each other. In the New York City terrorist attacks and in Israel, we have sort of calculated that the number of people who are at low risk of psychopathology, but who actually had psychopathology, probably equaled the number of people at high risk who had psychopathology. And of course, from the point of view of intervention, which is what this conference is about, this matters. Because what this says is that if we only focus our intervention efforts on this group, we are going to miss probably an equivalent number of people with psychopathology in this group down here. And that's a simple sort of reflection of the interplay between risks and absolute number of people who fall into a specific risk group. That's my first point in the conclusion. I'm going to skip these two slides. And let me just take my matrix that I sort of started off with and try to put it a little bit more in a public health framework. This is exactly the same set of different causes of disasters as I had up front. And what I've done here is I've changed my space-time intensity into mitigation, preparedness, response, and recovery. And I think this is a useful way, again, of applying what we know about psychopathology after disasters to the temporal sequence of potential interventions within which public health, public mental health can be engaged. And if you start thinking about mitigation, we're dealing with, in the context of natural disasters, there are things like building reinforcement for earthquake mitigation, reinforcing levees. I would argue that this kind of conference is bridging between mitigation and preparedness. Preparedness is biohazard containment units, tabletop drills, having staff ready to respond to disasters. The response effort is the acute response phase after these events, which may include things like rapid deployment of aid, emergency food and support, temporary shelter, and fundamentally, the recovery phase includes things like economic development aid, housing reconstruction, psychological counseling. And I think all of these phases are critical for us to successfully mitigate the consequences of disasters. I think I'm hopeful that the public health community meetings like this has sort of come around to recognizing this, and we are now becoming more and more engaged in each of these phases. Sometimes I despair a little bit that from a more national perspective or sort of national policy towards disasters, in my opinion, seems to be more that somehow we can prevent disasters from happening, which history is bearing out is unlikely to be the case. So I think from a public health perspective, if we understand both sort of what disaster types are, the factors that result in psychopathology after these events, and then how to map that onto specific steps we can take to minimize their consequences, I think we will potentially do good for a large number of people. I will just conclude, we'll leave this slide up. This is, Dr. Boulton mentioned this. This is the center which I co-direct. It's funded by National Institutes of Health. And what it is it's a free resource center for anybody who is, has the misfortune of being involved in a mass traumatic event and who would like assistance in evaluating the consequence of the event or evaluating the consequence of intervention. We have a sort of a staff of 8 faculty who will work with you if you haven't done this kind of work before. And there's also a number of other resources which you might find useful. Well, thank you for your attention. I'll be glad to take questions for a few minutes. Yeah, go ahead. The question is, I didn't speak much about resilience and what can be done to enhance resilience. The resilience, which has sort of emerged in the past few years as a particular sort of focus in and of itself, I frequently think of very much as a flip side of vulnerability. So I think one very simple way to think about building resilience is to be able to identify the risk factors that put people at risk for psychopathology after these events and do something about them. So for example, apart from sort of structural mitigation efforts, I think there is very little that one can do to predict who is going to be most intensely exposed. And that's, as we said, a substantial risk factor. However, we do know that social supports and immediate tending to physical needs of those affected by a mass trauma are one of the biggest predictors of psychopathology subsequently. So I think if I were to engineer a program to improve resilience, I would make sure that we deal with supports, both material and less material, both physical and psychological, for those who might be influenced by disaster. I think that would be one very, I wouldn't say easy, but it would be one very obvious way of increasing resilience in the population. I think in some ways, within a college campus type setting, one has a bit of an advantage that you have sort of a captive population. So I can imagine many more efforts to improve resilience within a captive population than you can in the general group. So, I mean, I'm not aware of anybody who has at all sort of successfully instilled resilience, but I think tending to the obvious risks is one way of doing it. And just one quick point before I get off this question. One of the sort of key controversies in this area is exposure to repeat traumatic events sort of inoculating you against psychopathology, or is exposure going to result in you being much more likely to have psychopathology in future? And it's a very tough question to answer from a research point of view. In my opinion, there's no good evidence fundamentally that repeat exposure inoculates people. I actually think that repeat exposure might, if anything, result in a greater risk. So I'm only saying that because I meant to say it earlier as a result of this question.
I have several. Is this working? I have several question cards here. The first question is asking in relation to the study on PTSD in Jews versus Palestinians, whether the increases in vulnerability in the Palestinians could be due to either perceived helplessness or an actual lack of resources to help oneself.
It's a very good question. The challenge in identifying sort of vulnerability is trying to identify whether this vulnerability is a reflection of material resources or lack thereof, or whether the vulnerability is a reflection of psychological dimensions of vulnerability, which includes things like perceived helplessness. And I think the answer is probably a combination of both. We didn't have the measures in the study to tease it apart. I think the two frequently are not addressed together in the same study because psychological dimensions typically tend to be addressed in psychology, while material resources tend to be addressed more in public health. But I suspect it's fundamentally a combination of both.
Another question. This one is concerning actually the train bombings in Madrid, and the question is whether you know anything about the prevalence of mental disorders in people who should have been more involved, like the college students who stayed home that day because of the strike?
I'm gonna say this answering the questions from the cards and addressing the audience is kind of strange. I feel like I'm doing like a thesis defense, you know. She's asking me questions and you're all evaluating it, and I don't know who asked the questions. So I don't know who to point at. Maybe people can just wave their hand when your question is asked. Hi, good. I'm glad it's your question. I feel much better now. I can look at you. No, we don't have a specific prevalence in the college population, but the population of Alcalá, which is the suburb where we did that, is largely sort of a group of, as I said, population of students and blue-collar workers who are relatives of those who are injured. So I suspect that prevalence we saw in Alcalá, which was about 10 to 15%, reflects the prevalence in sort of the middle tier of the pyramid I was showing you, which I think would include students in this situation.
Last question I have here is, has there been any research or data on the development of intentional communities of people who were affected after a disaster?
So did you say intentional?
Intentional communities is what this says. I don't know.
I might need some elaboration from the author of that question.
Anybody want to admit that?
Nobody's taking responsibility. I'm not sure what an intention.
Assuming that they mean sort of, I'm assuming that it's for rebuilding a community after a traumatic event.
Okay. Yeah, I'm not sure. I'm not sure that there is any good evidence about that, other than to say that there is substantial evidence that, as I answered in response to the gentleman's question, that responding to immediate material needs is probably one of the best things that any recovery effort can do. So insofar as a community rebuilding addresses material needs, it's probably immensely salutogenic. I've lost my questioner. I gave a short answer.
I can't read this. Okay.
He's disqualified on count of illegibility.
No, it's not illegible. It's too small. Anyway, I think maybe people could speak to you a little bit in the break because we are out of time. Or John, do you have a question?
I was just going to actually ask one more, Sandro. In basically the NIH monitoring project,
Yeah.
you looked at how media responds to impacts of
Yeah. Right. It's actually a very good question. We have, if I had more time, like 3 hours, I would have done the media part as well. We actually have a series of studies which I think are kind of neat. The third paper in the series was just accepted yesterday, actually, where we looked at the role of media in influencing post-traumatic stress. We focus specifically on post-traumatic stress, and what we have shown, semi-convincingly, is that those who are in the middle tier in my sort of pyramid, not the general population, but those who have some link to an event, but not an obvious link in the higher tier. And in that group, those who are exposed to a lot of media are much more likely to have post-traumatic stress and depression than those who don't watch media. And we're able to show that both in prevalent cases, in the most recent paper, and incident cases. They were able to show that those without symptoms, sort of people who already have some element of risk, when they watch media, they're at greater risk of developing incident post-traumatic stress or depression, which frankly isn't surprising, although the evidence on media is very sparse, and one gets into these sort of big nosologic debates about, well, is media exposure genuine exposure? But I think a combination of media with some pre-existing risk is putting persons at greater risk. I think that makes sense both physiologically as well as epidemiologically.
Okay, I think I got the gist of this question now. Basically, it's asking about whether you have any data about people who were exposed to chronic stress as children and in their developing brains where they're actually hippocampal and HPA axis changes, whether that's related to how those people respond at a time of disaster.
We don't, in the series of studies I showed you, there is no biologic data. In the Florida study, which Dr. Boulton mentioned when he introduced me, we have biologic data, but I don't have the data with me. But we have shown in our studies, and others have shown their studies, fairly convincingly, that ongoing stressors both before and after a mass traumatic experience are critical determinants of psychological well-being after an event. And by ongoing stressors, I don't mean simply trauma. So I don't mean being assaulted or being raped. What we actually mean is things like divorce and death of a parent or marriage. And it's pretty clear that there's a very sort of linear dose-response relationship, that the more stressors, completely separate and apart from the mass trauma, the greater the likelihood of psychopathology after mass trauma.
Okay. Any other questions? Okay.
Okay.
Okay. Thank you very much, Dr.
Thank you for your
Galea.
time.